we shall discuss about the mammary gland anatomy and breast cancer. The mammary glands are modified sweat glands present in the superficial fascia of the pectoral region. The mammary glands become well developed in females during the puberty period, while in males they become rudimentary. But sometimes in males also, mammary gland enlargement can happen, and this is called as gynecomastia. In females, they form a secondary sex organ and provide milk to the newborn baby. During dissection, right after the reflection of the skin, we can see the mammary glands along with the adipose tissue in the superficial fascia. With respect to surface anatomy, the gland can be observed as bilateral hemispherical bulge on the anterior thoracic wall. It extends vertically from the second rib to the sixth rib level, while horizontally it extends from the lateral border of the sternum to the mid-axillary line. A part of the upper outer quadrant of the gland extending into the deep fascia is called the axillary tail of Spence. It extends upward and laterally to enter the axilla. The aperture from where the axillary tail of Spence passes into the axilla is called as the foramen of Langer. Although usually benign, the axillary tail of Spence need to be considered in the diagnosis of axillary lumps and potential breast cancer. During dissection, once the skin is flapped off, we see the superficial fascia containing adipose tissue. Buried deep within this adipose tissue, we find secretory units and the lactiferous duct of mammary gland. Beneath the mammary gland, we have the pectoral fascia, which is a deep fascia covering the anterior aspect of the pectoralis major muscle. Between the pectoral fascia and the mammary gland, there is a space called the retromammary space, which is filled by loose areolar connective tissue. The presence of the loose areolar connective tissue in the retromammary space separating the pectoral fascia from the mammary gland allows the free movement of breast above the pectoral fascia. Now, beneath pectoral fascia, we have three muscles: the pectoralis major, serratus anterior, and external oblique. The external oblique is a muscle of the anterior abdominal wall, so the upper part containing the external oblique aponeurosis is related to the mammary gland. So from superficial to deep, we have skin, mammary gland, retromammary space containing loose areolar connective tissue, followed by the pectoral fascia, then the three muscles, pectoralis major, serratus anterior, and aponeurosis of external oblique muscle. The mammary gland consists of three anatomical components, which are the skin, the stroma, then the parenchyma or the glandular tissue or the mammary gland proper. The first anatomical component of mammary gland is the skin covering the breast. The skin again consists of nipple and areola. The nipple is the conical projection in the center of the breast, roughly at the level of fourth intercostal space, but it can vary from person to person depending on the amount of fat present in the superficial fascia. It is the most sensitive part of the breast and has rich sensory nerve supply, and also contains smooth muscle which helps in erection and flattening of the nipples. The second component of the skin is the areola, which is a circular pigmented area surrounding the base of the nipple. The areola contains large number of modified sebaceous glands, especially in its outer margin. These are usually known as the Montgomery's tubercle. The Montgomery's tubercle produce oily secretions that lubricate the nipple and areola, and it helps in preventing dryness and cracking. The areola becomes more pigmented and enlarged during pregnancy. The second component of the mammary gland is the stroma, which consists of the connective tissue as well as fat. Fat forms most of the bulk of the breast and is distributed all over the breast except for beneath the areola as well as the nipple. The connective tissue condenses to form fibrous strands or septa which are arranged radially, and these are called suspensory ligaments of Cooper. The suspensory ligaments of Cooper connects the dermis of the overlying skin of breast to the underlying duct as well as the pectoral fascia. The ligament of Cooper maintains the protuberance of the breast, and the atrophy of it due to aging makes the breast pendulous. The third component of the mammary gland is the parenchyma or the glandular tissue or mammary gland proper, which is involved in milk production. The parenchyma consists of about 15 to 20 lobes, which are radially arranged and converges towards the nipple. The lobes are divided from each other or separated from each other by means of fibrous septa, and each of the lobe is further divided into lobules, which contains clusters of acini, which produces milk. A main duct arises from each lobe called the lactiferous duct, and the lactiferous duct from each lobe converges towards the nipple and open at its summit. Just before its opening or termination, the lactiferous duct forms a dilatation called as lactiferous sinus, and the lactiferous sinus helps in storage of milk during lactation. The major arterial supply to mammary gland is via three arteries: the internal thoracic artery, lateral thoracic artery, and the posterior intercostal arteries. The internal thoracic artery is the major artery that branches from the subclavian artery and descends along the inside of the anterior chest wall. It supplies for the mammary gland through the perforating branches, which pierces the second, third, and the fourth intercostal spaces. The second one, that is the lateral thoracic artery, is a branch of the axillary artery which runs along the lateral border of the pectoralis minor muscle. Along with the lateral thoracic branch of axillary artery, the superior thoracic branch as well as the acromiothoracic branch also supplies for the mammary gland. The posterior intercostal arteries running in between the ribs also supply the mammary glands through its lateral branches. The veins correspond to the arteries, but they flow in the opposite direction. Thus, the venous drainage of mammary gland takes place by the axillary vein, the internal thoracic vein, and the posterior intercostal vein. The veins converge at the base of the nipple to form an anastomotic venous circle, and from here they run into two sets, the superficial as well as the deep set. The posterior intercostal veins drain into the vertebral venous plexus indirectly by communicating with the intervertebral veins. Because of this reason, the metastasis from the breast cancer has a chance to spread into the brain through the venous route. The posterior intercostal veins, which are present between the ribs, drain the posterior part of the thoracic wall. They drain into the intervertebral veins, and the intervertebral veins then drain into both the external as well as the internal vertebral venous plexus, which run along the vertebrae. These plexuses are continuous with the vertebral veins, so from here the metastasis can transfer into the intracranial dural venous sinuses and then into the brain. Coming to the innervation of mammary gland, the nerve supply of the breast is primarily somatosensory. It is derived from the second to the sixth intercostal nerves through their anterior as well as lateral cutaneous branches. The afferent sensory information from the skin, the areola, and the nipple is important for stimulating milk production and release from the mammary gland in response to suckling by the infant. Although the production is having a neural control, the release of milk is not under neural control. It is by the prolactin hormone. The sympathetic autonomic fibers supply to the smooth muscles and the blood vessels of the breast. The lymphatic drainage is the most clinically important anatomical aspect with respect to the mammary gland. In order to discuss about the lymphatic drainage, we'll have to discuss about the lymph nodes draining the breast as well as the lymphatics draining the breast. There are mainly 5 groups of lymph nodes, which are axillary lymph node, internal mammary lymph node, supraclavicular nodes, posterior intercostal nodes, as well as cephalic or deltopectoral nodes. The axillary lymph node is the first group. It lies in the axilla. This group is again having 5 subgroups. There is an anterior or pectoral group. There is a posterior group, central, lateral, as well as apical group. The second one is the internal mammary nodes or the parasternal nodes, which lie in the lateral side of the sternum, that is along the internal thoracic vessels. The third group is the supraclavicular nodes, which lie above the clavicle. The fourth group is the posterior intercostal nodes lying in the posterior part of intercostal spaces. And the fifth is the cephalic or the deltopectoral nodes lying in the deltopectoral group. Now, in addition to these 5 lymph node groups, the lymph from the breast is also drained into the subdiaphragmatic as well as subperitoneal lymph plexus. After discussing the lymph node, we'll have to discuss about the lymphatics of the breast. Now, lymphatics are the channels through which the lymph fluid flows. With respect to mammary gland, there are two groups of lymphatics. There is a superficial group as well as a deep group. The superficial lymphatics drain the skin except the nipple and the areola, while the deep lymphatics drain the parenchyma as well as the skin of the nipple and the areola. Now, while discussing the venous drainage, we had discussed about the presence of an anastomotic venous circle which is present at the base of the nipple. Parallel to this, there is a plexus of lymph vessels which lie deep to the areola and is called the subareolar plexus of Sappi. Now, interestingly, the lymph from the subareolar plexus of Sappi, as well as from most of the breast, drain into the anterior group of axillary lymph node. Another interesting aspect is that the superficial lymphatics of breast communicate with those of the opposite side. That is, the superficial lymphatics of the right side can communicate with that of the left, and that of the left can communicate with the right. So this means that there is always a chance that an unilateral malignancy can become a bilateral one. In order to study the directional flow of lymph from the mammary gland is divided into 4 quadrants. A horizontal line divides it into an upper and a lower section, while a vertical line divides it into an imaginary inner and an outer section. Thus, we have 4 quadrants. There is an upper outer quadrant, an upper inner quadrant, a lower inner quadrant, as well as a lower outer quadrant. Now, coming to the directional flow of lymph through the lymphatics into the lymph nodes, this is the most important point to be understood in the anatomy of breast because breast cancer is common and especially among women, and there is a high chance of spread of breast cancer to other organs through the lymphatic channels. So the lymph from the lateral quadrants, that is both the upper outer and the lower outer quadrants, drain mostly into the axillary lymph nodes, especially into the anterior subgroup of axillary group of lymph nodes. The rest of the lymph drain to the posterior as well as the lateral subgroups of axillary lymph node. The lymph from the anterior, the posterior, and the lateral group drain to the central group, and from there to the apical group of lymph nodes, and from apical it drains to the supraclavicular lymph nodes. From the inner or the medial quadrants, majority of the lymph drain into the inner mammary or the parasternal lymph nodes. So about 75% of the lymph from the breast is drained into the axillary lymph node, especially into the anterior group of axillary lymph node. About 20 up to 25% into the internal mammary lymph node, and about 5% into the posterior intercostal lymph nodes. In addition to the lymphatic drainage flow that we have discussed so far, there is also chance of flow of lymph from the upper outer quadrant into the deltopectoral lymph node. From the lower outer quadrant, there is a chance of flow of lymph into the posterior intercostal lymph node, and from the lower inner quadrant, it can pass into the subperitoneal as well as the subdiaphragmatic lymphatic plexus. The lymphatic communication between the inframedial or the lower inner quadrant with the subperitoneal lymphatic plexus can cause the spread of cancer from breast into the ovary. So there is a secondary tumor which can be caused in the ovary, and this is usually referred to as Krukenberg's tumor. Growth in the breast can either be benign or malignant, that is cancerous. Cancer in breast arise from epithelial cells lining the lactiferous duct or acini of lobules. Breast cancer can occur both in males as well as females. 60% of carcinoma of the breast occur in upper lateral quadrant, and mostly breast cancer occurs in females of 40 to 60 years of age. Presence of a visible lump, changes in the color or texture of the skin overlying the breast, changes in the nipple, especially inversion of nipple, appearance of dimpling over the skin of the breast, as well as any discharges through the nipple. All these can be early warning signs of breast cancer. This requires immediate medical attention and examination. The retraction of nipple occurs due to infiltration of lactiferous duct by the cancer cell. The purely orange appearance of the skin happens because the hair follicles appear to be retracted beneath the level of the skin because of obstruction of lymphatics by the cancer cell. In case the retromammary space is infiltrated by cancer cell, there can be a chance that the breast will not be moving freely over the pectoral fascia. All these are significant or important clinical findings with respect to breast cancer. Due to extensive lymphatic as well as vascular connection, breast carcinoma can cause secondaries in brain, bone, lungs, and liver. Regular self-examination is very important for early detection. Inspecting both the breast in front of a mirror to look for discharge, skin dimpling, or retraction of nipple is important. This can be followed by palpation both in the lying down position as well as in the standing position in order to look for any unusual mass or lump below the skin. Mammography is an X-ray based screening tool to detect early signs of breast cancer or other breast diseases by producing images of the breast tissue. There are two types. There's a screening mammogram as well as a diagnostic mammogram. A screening mammogram is a routine examination for women, even with no symptoms, to detect early cancers in order to facilitate early treatment. A diagnostic mammogram is used to evaluate breast symptoms such as lumps, pain, or nipple discharge and can be used after screening mammogram to find any abnormality. Medical management of mammary gland malignancy includes surgical removal of cancer tissues, radiation therapy, hormone therapy, chemotherapy, and targeted therapy. The surgical removal of mammary gland is known as mastectomy. Sometimes a radical mastectomy is done. In radical mastectomy, the whole of the breast is removed along with the axillary lymph nodes as well as the pectoralis major and minor muscle. Thus, we have covered the gross anatomy of mammary gland along with some relevant clinical points. Hope it was helpful.